suddenly, out of the corner of your eye, the check engine light flashes red on your dashboard.
Oh, the worst feeling.
Instantly, your heart drops. You grip the steering wheel tighter. You turn down the radio and start listening for weird clunks, completely convinced the car's about to just explode on the shoulder of the road.
Even though the car is driving exactly the same as it was 10 seconds ago?
Exactly. But what if there's absolutely nothing wrong with the engine? What if the sensor itself is just hallucinating?
I mean, your car is perfectly fine, yet your entire reality inside that cabin has shifted from a state of total safety to, well, imminent disaster.
Yeah, the physical world hasn't changed at all.
Right, but your perception of it has been entirely rewritten by a single false signal.
And you sitting right there listening to this, you probably know exactly what that panic feels like. And today, we're going to show you how that exact check engine panic is basically the hidden engine of our entire modern medical system.
It really is. So you wake up with a strange symptom, right? Maybe it's a really persistent deep chest cough, or, I don't know, a rash that definitely wasn't there yesterday.
Right, and the immediate instinct for almost everyone is panic.
Exactly. You feel that spike of anxiety, you grab your keys, and you just rush to the hospital or, the local urgent care clinic.
Yeah, because culturally, we view that building as this ultimate sanctuary.
Totally. Like, the second you walk through those sliding glass doors, you feel like you're in the safe zone, the healing zone.
Yeah, it's the designated safe space. I mean, we're basically programmed from childhood to view healthcare facilities as the absolute peak of sterility.
Right, a place where all biological threats are just neutralized. But today, we're doing a deep dive that's going to, completely flip that script.
Yeah, it's a pretty sobering topic.
It really is. We're diving into medical research papers, hospital contamination studies, and the autobiographical writings of Dr. Kadiyali Srivatsa.
Right, a physician who's spent decades studying the spread of antibiotic-resistant bacteria.
Exactly. And our mission today is to explore this really terrifying realization. The very place you run to when you feel sick, it might actually be the most dangerous place you could go.
Because hospitals and healthcare centers have inadvertently become the epicenters of antimicrobial resistance, or AMR.
Yeah, but before we get into the hospital stuff, let's ground this. What exactly is AMR at a biological level? Why are the stakes so high right now?
Well, to really grasp the scale, look at something like MRSA. So that's methicillin-resistant Staphylococcus aureus.
Okay, that's a mouthful.
It is, yeah. But staph is just a really common bacterium. MRSA, though, is a strain that has basically built biological armor.
Biological armor.
Yeah, it acquired this specific gene that alters the binding sites on its cell wall. So when we introduce penicillin or any of its modern cousins, the antibiotic literally can't attach to the bacteria.
It just bounces off.
Basically, yes, it just bounces right off.
Right.
So you're facing this reality where totally routine infections could become entirely untreatable.
Man, that is terrifying. And, the best analogy I found while looking through Dr. Srivatsa's notes and all the contamination data, it really changes how you look at a hospital.
How so?
Well, it's not a sanctuary at all.
Mm-hmm.
A modern hospital functions much more like a bustling international airport.
Oh, that's a really good way to put it.
Right. You have people arriving from all over the community, and they're bringing in all their different baggage. But here, the baggage is this wide array of pathogens.
Yeah, and they're constantly swapping that baggage.
Exactly. Leaving it on chairs, passing it to the staff, picking up someone else's, and then just walking right back out into the world.
And I mean, the wildest part is that the most intense swapping happens before you even see a doctor.
You mean in the waiting room?
Yes, the waiting room is this massive blind spot in infection control.
How is that possible? I mean, everyone is sick in there.
Well, hospitals classify places like intensive care units or operating theaters as critical areas, right? So those get intense air filtration, rigorous sterilization. But waiting areas, they're generally considered non-critical.
You're kidding. Non-critical.
Yeah. So you have these undiagnosed, potentially highly infectious patients sitting literally shoulder to shoulder with really vulnerable people.
Oh, wow. So someone with a compromised immune system is sharing the exact same airspace and the same chairs as someone harboring a drug-resistant respiratory infection.
Exactly. They are in direct contact with all of those surfaces.
But I got to ask, aren't hospitals constantly cleaning these areas? You see them using that industrial-grade bleach, and some have those cool automated UV light robots at night.
You'd think that would be enough, right? But the biology of these pathogens actually defeats standard cleaning protocols.
How so?
Let's look at Acinetobacter. It's this multi-drug-resistant bacteria notorious for hospital outbreaks. It doesn't just sit on a surface waiting to be wiped away. It forms what we call a biofilm.
A biofilm. Like a shield.
Yeah, a lot like a shield.
Okay.
It secretes this sticky, sugary matrix that acts like a microscopic bunker.
Oh, man.
Right. So when the cleaning staff comes through with a bleach wipe, the chemical hits the outer layer of that bunker and kills the surface bacteria. But the microbes deeper inside,
They survive.
they survive. And once the surface dries, they simply multiply and recolonize the area.
That is wild.
Yeah.
And the sources were saying they can survive on dry surfaces for an incredibly long time, right? Like a laminated information sheet or a waiting room chair.
Months in some cases. Months.
Wait, really? Months?
Yeah. And because of the sheer volume of human traffic, those surfaces are recontaminated almost instantly anyway.
Right, because people are constantly touching them.
Exactly. There was this one study from a U.S. hospital that tested objects patients touch regularly, like a ward call button.
Okay.
The data showed a 90% chance of infection transfer if you touched that highly contaminated, frequently used item.
90%.
Yeah. The resilience of the biofilm plus the frequency of human touch, it basically guarantees transmission.
Honestly, that makes sitting in the waiting area sound like playing Russian roulette.
It really does.
But okay, let's say you survive the waiting room. You finally hear your name called. You walk through those double doors down the hall, and you enter the examination room.
Right, and psychologically, there's a big shift there.
Totally. You think, okay, I've escaped the public zone. I'm in the sterile clinical environment now.
But that illusion of safety is perhaps the most insidious part of the whole visit.
Yeah, reading Dr. Srivatsa's observations on this completely shattered that assumption for me. Like, the whole idea of personal protective equipment, or PPE.
Right, you see a doctor put on gloves and a mask, and you just assume this impenetrable barrier has been created.
But the glove boxes themselves, that part really caught my attention in the sources.
Oh yeah, they open boxes.
Yeah. A doctor walks in and pulls a pair of unsterile gloves out of this open cardboard box mounted on the wall.
Mm-hmm.
But the cardboard itself, the plastic dispenser, the surrounding drywall, they're completely colonized by bacteria and fungi.
Exactly. So the mechanism of contamination happens in an instant. If the dispenser is a microbial reservoir, the physical act of just dragging the glove out of the box contaminates the outside of the glove.
Right. And then the doctor touches your skin, or worse, your wound, with a pathogen they literally just picked up from the cardboard packaging.
It entirely defeats the purpose of the barrier.
It's crazy. And it extends to the doctors themselves, too. The data paints this really grim picture of healthcare workers acting as vectors.
We do tend to forget that doctors rarely change clothes or, shower between seeing patients.
Right. I was reading this study in the source stack where up to 79% of white coats tested in a hospital were contaminated with MRSA.
That's 89%.
Yeah, because the long sleeves are constantly brushing against patient beds, door frames, medical equipment.
The white coat is like this ultimate symbol of medical authority. But from an epidemiological standpoint, it is a mobile contamination unit.
A mobile contamination unit. This is so creepy. And then there's the necktie experiment.
Oh, that one is fascinating.
I have to explain this because it brilliantly illustrates how these bugs physically move around. So researchers set up this mannequin experiment where a physician wore a tie that was artificially inoculated with a test bacteria.
Right. They seeded the tie with bugs.
Exactly. And the doctor just performed a routine examination, leaning over the mannequin to listen to the chest. That contaminated tie increased bacterial transfer to the patients sixfold.
Because a tie dangles.
Exactly.
Gravity pulls it forward when a doctor leans over to check your breathing or use a stethoscope. So it physically drags across your skin or your gown, picks up whatever microbes are there, and then swings right onto the next patient in the next room.
It's basically a microbial paintbrush.
That's exactly what it is.
They're unknowingly swiping a dangerous pathogen from one canvas to the next all day long.
Yeah.
And that paintbrush effect applies to the medical equipment, too.
Oh, definitely. The examination couch, the stethoscopes, the otoscopes they use to look in your ears.
And the sources specifically called out radiology departments as major intersections for this, right?
Oh, yeah. Radiology is the central hub. Almost every patient, regardless of their specific ailment, eventually passes through an X-ray or an MRI machine.
Right.
And the swabs from these departments show rampant contamination on the keyboards, the patient tables, and especially inside the bores of MRI machines.
Well, yeah, an MRI bore is that tight enclosed tube.
Exactly. It's incredibly difficult to clean thoroughly between every single scan, so it makes it highly prone to MRSA colonization.
Okay, so if standard cleaning isn't working and the PPE is failing, how did we actually figure out who was spreading these superbugs?
Well, this brings up a really pivotal moment from Dr. Srivatsa's career in the 1990s.
Right, when he was working in a pediatric critical and intensive care unit.
Yes. So he noticed that babies who were otherwise being treated properly were suddenly becoming unstable. They were showing early signs of MRSA.
And the standard protocol when an outbreak happens is usually to look for, like, contaminated equipment or find a sick patient who brought the bug into the ward.
Right. Usually, yes. But Dr. Srivatsa took a completely different approach. He actually swabbed the doctors and the nurses.
Which was a huge deal.
Yeah.
And he discovered that certain nurses were acting as carriers.
Yeah.
And the key detail here is that these nurses weren't sick. Like, they didn't have fevers or lesions. They didn't even test positive for an active MRSA infection themselves.
But they were harboring the microbe, and he proved it because when he switched the nurses assigned to those specific babies, the babies stabilized.
The microbes on the nurses were literally interacting with the babies. But, and this is the crazy part, when he tried to publish these findings, the medical journals pushed back hard.
Oh, the resistance from the medical establishment was fierce because it challenged the foundational hero narrative of medicine.
Right.
I mean, it's so much easier for a hospital administrator to blame a dirty floor or, a sick visitor than to accept that the healers themselves, their own hands, their ties, their coats, are the primary vectors.
But his discovery forces us to confront this massive biological difference between being infected and being colonized.
Yes. And understanding colonization is absolutely central to surviving the AMR crisis.
Let's break that down for everyone listening, because this blew my mind. What does it mean to be colonized?
Well, if you are infected, the bacteria have actually breached your defenses. They've entered your bloodstream or your deep tissue. Your immune system mounts this massive inflammatory response, and you feel sick.
Okay, that makes sense. So what's colonization?
Colonization is completely different. Think of it like dandelion seeds resting on a wool sweater.
Oh, that's a great image.
Right. The dandelion isn't growing roots into your skin. You aren't infected. The bacteria is just hitching a ride in your nostrils or on your skin or in your gut.
And because your immune system hasn't been triggered at all, you feel perfectly fine.
Exactly. You are a silent carrier.
So if I'm colonized and I feel great, why is that a crisis?
Because as you move around, you are constantly shedding those seeds. We shed millions of microscopic skin cell squames every single day.
Right, the squames. So if I have MRSA colonized on my skin, every time I brush against a door frame or sit in a waiting room chair or touch a bed rail, I'm just leaving a trail of those seeds behind.
And that is catastrophic for the hospital ecosystem. Because you might be fine, but the next person who touches that bed rail might be, say, a cancer patient with a suppressed immune system.
Oh, wow.
So the bacteria transfers to them, finds a weakened host, breaches their defenses, and causes a lethal, untreatable infection.
And the sheer scale of this is staggering. One of the hospital studies in the sources looked at data from areas with high population density.
Yeah, areas with major antibiotic stewardship challenges.
Right. And they found that up to 83% of patients in a facility were colonized by resistant organisms. 83%.
It's massive. And when 83% of the people in a building are silent carriers shedding superbugs, the architecture itself just turns into a massive, self-sustaining reservoir of disease.
It literally ceases to be a place of healing.
Yeah.
Which, I mean, that forces a massive strategic shift, right?
It absolutely does. If the danger is baked into the hospital environment, the primary goal of public health has to be keeping people out of the hospital unless it is an absolute medical emergency.
So if rushing to the hospital exposes you to MRSA and other superbugs, what on earth should you do when you feel sick?
Well, we have to shift from reactive medicine to proactive triage. The strategy now is to identify and isolate at the household level.
Before the pathogen ever crosses the hospital threshold.
Exactly.
Which is where Maya AI comes into the picture. Dr. Srivatsa actually developed medical advice you access, or may I, specifically to triage patients at home.
Yeah, it's a really vital innovation.
I looked at the color logic behind this system, and it completely flips standard medical advice on its head.
Well, Maya AI isn't just, a basic flowchart or a BuzzFeed-style symptom quiz.
Right, it's way more advanced.
It uses a complex logic engine that mirrors a physician's actual clinical acumen. It maps symptom clusters against epidemiological data to determine not just what you might have, but the statistical risk you pose to a clinical environment.
And the outputs are categorized into 4 colors. So red is straightforward, Right.
Yeah, red means urgent danger. Seek immediate emergency care.
Right. And green means it's a minor issue. You can manage it by just consulting a nurse via telehealth.
Exactly. And yellow means you can rely on self-diagnosis or a pharmacist for over-the-counter relief.
But the blue code is the really fascinating one, because if you hit blue, the system has detected a symptom cluster that indicates a potential contagious infection.
Right.
And the immediate instruction is to isolate at home. Do not go to the doctor.
The blue code is basically a pandemic prevention mechanism. It tells you to protect your community by staying put and utilizing remote consultations.
I have to push back on this, though, just from a liability and safety standpoint.
Sure.
We have been conditioned our whole lives to believe that early physical intervention by a doctor is the gold standard of care. Isn't it a massive calculated risk to tell sick people to stay home? Like, what if someone mismanages a symptom and gets worse?
It is a calculated risk, definitely. But we have to look at the mathematical probability here.
Okay.
First, the system explicitly preserves doctor autonomy. It doesn't try to manage a red code emergency.
Right. If you're dying, go to the ER.
Exactly. But for minor or moderate contagious symptoms, the math has just fundamentally shifted.
How so?
The statistical probability of an otherwise healthy person catching a lethal, untreatable AMR strain by just sitting in a contaminated waiting room for 3 hours, that risk is now actually higher than the risk of them mismanaging a minor respiratory virus at home with telehealth guidance.
Wow. So AI triage is no longer just a convenience. It's a mathematical necessity.
Yes, it's a double-layered protection.
Right. Because you keep the mildly ill person at home so they don't pick up a lethal superbug they didn't even have when they walked in.
Exactly. And simultaneously, you decompress the healthcare system. You save those uncontaminated hospital beds for the people who are truly critically ill.
You're severing the transmission chain at the front door of the patient's house.
Yes, rather than trying to fight the bacteria once it's already circulating in the hospital vents.
This requires completely rewiring how we interact with the medical system. We have to stop viewing the hospital as this pristine sanctuary and really recognize it as a massive hub of invisible, swapping baggage.
It's a huge paradigm shift.
It really is. I mean, We've tracked the mechanics of this danger today, from the biofilm bunkers of Acinetobacter on the waiting room chairs
to the false security of those contaminated glove boxes.
and the doctor's tie acting as a microbial paintbrush.
Yeah, that one always sticks with people. And we've established that colonization turns healthy people into silent spreaders.
Shedding pathogens like dandelion seeds across every surface they touch.
Exactly.
The ultimate takeaway here is that the solution to antimicrobial resistance isn't just, sitting around waiting for pharmaceutical companies to invent a stronger pill.
No, it can't be. The solution is behavioral.
It's taking ownership of your own exposure, observing your surroundings, using common sense, and really questioning the necessity of a clinic visit for just a minor sniffle.
And utilizing tools like Maya AI to triage at home, to protect your family from unnecessary exposure.
Right, isolating those infections before they can feed the hospital reservoir.
You know, when you zoom out and look at the trajectory of these superbugs, it leaves us with a pretty profound architectural question.
Oh. What do you mean?
Well, as AMR continues its exponential rise and these pathogens become ever more resilient to our chemicals, how long will it be before the physical structure of our hospitals is forced to radically change?
Wow. What would that even look like?
I mean, will we see the end of the communal waiting room entirely? Maybe replaced by, isolated intake pods?
Oh, like individual bubbles?
Yeah. Or will the fabrics healthcare workers are allowed to wear be strictly legislated, like banning ties and long sleeves forever?
Just scrubbing the white coat from existence.
Exactly. We are rapidly approaching a threshold where we will have to fundamentally redesign the hospital just to protect us from the buildings themselves.
Man, it really makes you wonder if 50 years from now, walking into a clinic will look less like stepping into a lobby and way more like passing through a biosecure clean room.
It's very possible.
Definitely something to keep in mind the next time you reach for that laminated information sheet in the waiting room.